Okay, G am Trnona Rinusle to Falcho Rove Galers Gajian Lake Shahanyu. It's more an honor gumsim our last chain Taija Galashin and on and Noliach the Social Tagus Lane Kelty, Kaincherella Coronat Najiv in you and Arthra, Leachti de Ullen and US Galashta. You're all very welcome to a further lecture in our College of Arts, Social Sciences and Celtic Studies New Professors Inaugural Lecture Series. It's a great honour as Vice Dean for Research in our college to chair today's lecture, the 10th in our series to date, which has featured contributions in the areas of social policy, education, political thought, online therapies, language transmission, historical research, behavioural psychology, the Irish song tradition and Irish literature and culture. These lectures have provided a very important platform for us as a college to shine a light on the pioneering and groundbreaking research work being undertaken by colleagues in the wide range of disciplines in our college, as well as providing us with the opportunity to celebrate the work of leading researchers. I'm very grateful to Professor Dan Carey, to David Kelly and to Martha Shottenshee in the Moore Institute for their support in facilitating us in moving our series online for today's lecture. It's a great honour to introduce today's speaker, Professor AnnMarie Groarke. I'm grateful to Professor Groarke for agreeing to give today's lecture online. We would all prefer, of course, to be in our usual venue in the Moore Institute, Hardiman Research Building, but the online platform does provide additional possibilities, allowing for the attendance of a much wider range of individuals in Ireland and internationally through both the Zoom and Facebook, Moore Institute Facebook platforms through which this lecture is being relayed. There's also the opportunity for those attending to raise questions via the chat and Q&A function on Zoom at the bottom of your screen, and I will bring these questions to AnnMarie's attention at the end of her lecture. For people watching on Facebook, there's also the possibility to raise questions on that forum that I will also raise at the end of the lecture. Professor Groarke was appointed as personal professor in 2019 under a leadership track which, along with evidence of excellence in research scholarship, requires an outstanding record of academic leadership which delivers significant and quantifiable improvements to the university performance. She has held a wide range of leadership roles across the university and indeed beyond since her initial appointment in NUI Galway, including as director of the Masters in Psychological Science and Health Psychology program from 1998 to 2002. And she was also the chair of the Psychological Society of Ireland Health Psychology Special Interest Group for a 2-year term during that time. She has been Vice Dean of the Arts Faculty from 2003 to 2006 and head of the School of Psychology from 2009 to 2017. Professor Groarke led her school through a significantly challenging time of severe cutbacks, particularly during the long period of economic recession that persisted from 2009 through 2014. Despite these challenges and pressures, the school achieved significant improvements across key performance indicators, which enhanced the national and international profile and reputation of the School of Psychology and of our university as a whole. With an ambitious academic vision and business plan for expansion, the School of Psychology over the duration of Professor Groarke's leadership showed considerable growth in academic programs, student recruitment, capital resources, including a new building for psychology at the centre of our campus, increased academic staff numbers, and a significant rise in research publications and funding awards. In addition to her role as head of school, Professor Groarke served as national delegate for Ireland to the European Health Psychology Society for a number of years and served as a member of the scientific committee for the EHPS Health Psychology Society Conference in 2005 and 2006 and as track chair in 2013 and 2015. She's a member of the board of directors of Cancer Care West since 2012 and is currently Deputy Dean in the College of Arts, Social Sciences and Celtic Studies. Professor Groarke's main research interests and publications are in health psychology and focus on psychological adjustment to illness, particularly understanding factors that predict variability in adaptation. She's also published research with other collaborators, including on themes of stress and music listening, risk perceptions and cancer worry in healthy women, adolescence adjustment at a time of maternal cancer, and women coping with chemotherapy. Over the last number of years, she's conducted a program of collaborative research with colleagues in psychology and cancer specialists at Galway University Hospital to examine the psychological impact of breast cancer and prostate cancer. Her funded research in cancer has examined patient experience during biopsy, diagnosis, treatment, and post-treatment phases. In addition, a clinical trial she led that demonstrated the efficacy of a cognitive behavioral stress management program for women with breast cancer was the largest randomized controlled trial in this area to date in Ireland and one of the first in Europe. She was also involved in setting up postgraduate programs in health psychology, and NUI Galway is now an internationally renowned centre of excellence in this area. She also spent time as a visiting scholar in 2014 and 2018 at the leading Center for Psycho-Oncology Research at University of Miami, USA. In her talk today, titled What Enhances or Hinders Psychological Adjustment to Chronic Illness for Women and Men, a Program for Research, Professor Groarke will share findings from her research on psychological adjustment in patients with cancer and arthritis.
Thanks, Sean, for that very comprehensive introduction. And I'll just launch in now, so straight away. Okay, good afternoon. And as I said, thank you for that lovely introduction from Sean. And what I'm going to be talking about this afternoon is a program of research that I've done over the last number of years on adjustment to chronic illness. Sean, this doesn't seem to be moving forward. Hold on a second. I think I know. Yeah, hold on. I need to do start slideshow, sorry. Yes, from start. Excuse me, these are all the technical issues. This is all very new. And I want to acknowledge the person who I've worked with for, and I won't mention the number of years, and my colleague and dear friend, Professor Ruth Curtis, who also had leadership roles in our university. She's former vice president. And to acknowledge as well all our medical collaborators who this research wouldn't have been possible without Dr. Coughlin and Gazelle, who are a consultant rheumatologist, and Professor Michael Kern, who's a consultant general and breast surgeon, and director and head of surgery at NUIG and School of Medicine, and Professor Frank Sullivan, who's a consultant radiation oncologist and director of our Prostate Cancer Institute here in the university. So thinking about chronic illness, well, it's an illness that can be managed, but it cannot be cured. And examples would be asthma, diabetes, cancer, because people are surviving quite longer durations now with that, and cardiovascular disease as well. It's responsible for about 70% of deaths worldwide, and in the USA, for example, half of all adults have one or more chronic conditions. And we in Ireland, about 1 million of us have them, and 2/3 of people over 65 would even have 2 or more to deal with. There's a lot of psychological sequelae to chronic illness. They range from physical difficulties around pain and disability, psychosocial problems. There's a lot of uncertainty, even to the extent that your life might be in jeopardy, loss of control. There's often a loss of autonomy, and you're very dependent on kind of even medical care, etc., and care of relatives. There can be mood changes. People can get very anxious, and over time can, the difficulties of trying to deal with the trauma of the chronic illness and the diagnosis can actually cause depression or lead to depression. And also there's significant disruption to a lot of our typical roles that we play in family, in work, and our social life. And as I said, sometimes people find it very difficult because they also now find that they sometimes have to depend on other people. So there's a loss of autonomy. The research shows us that the most stressful situations are ones that actually force people to restructure their identities and their social roles, and are events that have no clear endpoint. And chronic illness really has to do with retention and loss, and that's not just of ourselves, but really of a way of life. So it presents significant challenges on diagnosis. And there's a lot of variability across individuals in adjustment, but in the main, people adjust well over, you know, a year or two, or in the first year, perhaps, most people. But for a third, the adjustment phase is prolonged and it's unsuccessful. And really, it's important that we try to identify the factors that might enhance or disrupt adjustment, because that allows us to target resources to those people who are most in need. So not everybody will need psychological input or care, but a significant minority will do so. So how would we describe unsuccessful adjustment? Well, really it's your life has kind of gone out of balance, but you're finding it hard to regain that balance. There'll be a disproportionate amount of distress, which would be anxiety, depression, negative affect. There'll be a lot of interference in being able to engage in your normal roles and relationships. You might have poor illness management. You won't be able to manage your symptoms. You mightn't be adhering properly to your treatment regimen. And in recent years, we beginning to identify that we should also look at the idea that there's low positive affect. It's not just that there's depression and distress, but there's low positive emotions. Like there's an inability to kind of find joy or be enthusiastic or be energetic. And so that's an important aspect of our lives, and we would want to maintain that. Now, looking at theoretical models, and Ruth and I were, when we were starting out our program of research, or in health psychology generally, one model that we found fairly interesting was a model on self-regulatory model of illness behaviors. And we thought that that might offer a useful explanation for this inter-individual variability. And basically what it means is that we all kind of have ideas and concepts and representations around illness. And we create our own models or representations of disease, etc. And there was subsequent to that model, there was a ton of empirical research on this, and really there was great consistency in showing across multiple populations, etc., and across multiple diseases, that we tend to construct illness around 5 domains or dimensions. One is that it's identity, and that really is the experience and the perception of symptoms that are linked to the illness. So if, for example, you feel congestion or fever or headache, you might construct that or put a label on that as, oh, I have a flu. Currently, it might be quite a different construction, but we won't go there. What are the causal mechanisms of the illness? And we think it might be hereditary, like, maybe genetic mutations for cancer, or it could be internal or external. For example, if we think of our flu example, it would be external in terms of its virus, but internal factors might be playing a part too, because you might have low immunity, so you're more vulnerable to that virus. We also think of illness in terms of its chronicity or its timeline. So an illness could be chronic, could be acute like the flu, or it could come back in waves and cycles, and sometimes rheumatoid arthritis has disease flares that are cyclical. Also, we think of illness in terms of its consequences, its expected outcomes, and it could be death, it could be disability, it could be impact on our health, our social life, our financial situation. And finally, we think of illness in terms of, can it be controlled? How do we recover? And sometimes we can have representations that we ourselves are kind of in a position of agency to be able to control the illness in some ways, or the symptom management, or it might be that it is amenable to medical intervention, etc. So each of those components holds with it's an aspect of the illness, but taken all together, then they give you a sense of the individual's coherent view of an illness. So Ruth and I decided we would look at those perceptions in relation to rheumatoid arthritis, which is a chronic disease. It's really characterized by a lot of disabling inflammation of the joints, and the course of the illness is variable because, as I said, it's subject to disease flare, and it is progressive. It's an autoimmune disease, actually, where the immune system sends antibodies that attack the lining of the joints and the healthy tissue, and then there's progressive deterioration there, which is disabling. So there's a lot of pain, reduced flexibility, mobility, and fatigue. But when we talk to clinicians about this and the rheumatologists, there was an assumption and a belief, and it's in the literature too, that depression can often frequently accompany RA. And the issue of that is that it can have clinical, as well as being very distressing to the patient, but they also will tend to report increased distress about the symptoms. They'll report more pain to their GPs. They might look for more medications, and they'll often have more visits to the clinic, etc. Now, there could be physiological mechanisms, and there are, in terms of probably immune and neurotransmitter dysregulation in depression, that kind of activate autoimmune mechanisms that play a role in RA. But our question was, but is the disease process solely responsible? You know, is RA, you know, synonymous with depression? And then, so we took this model about the way people think about illness, and we said, well, where do they play a role in adjustment to arthritis? And we did a study with 75 women over in the outpatients in the university hospital. The mean age is 60, and they had their disease for about 13 years. Now, this was a 3-year study. We did a yearly assessment over 3 years. But today I'm just going to kind of summarize. We found great consistency across the 3 years in our results, so I'm just going to summarize. And one of the things we did in conjunction with the rheumatologist was, when we were doing our psychological interview and doing the questionnaires with the patients, there was a blood draw. And so we were able to have kind of objective indices, medical indices of inflammation. And they are erythrocyte sedimentation rate and C-reactive protein. We also got the clinician to rate the number of joints that were involved in the arthritis. And then we used an illness perception questionnaire, and a questionnaire that taps into different areas of impact for your arthritis. So we did what's called a regression analysis, and basically that's a technique that just looks at links across variables. But in this we can, so all of the variables that I'm talking today are always one-on-one related to the outcomes. But we were interested in really looking at the group of variables together. And what this regression analysis allows you to do is put variables in sets and in steps. So you start off and enter your age and illness duration into the equation, and you can see that really didn't affect the reports of the women for their physical functioning, and there was a load of sub-items on that, and activities of daily living, their pain, their anxiety, and their depression. Then we were able to take all the measures I've just mentioned on disease and put them in as a set next, and see what additional explanation or how would they predicted the scores on those outcomes. And then after that was taken care of, and we then were able to input the 5 illness beliefs and the scores on that. And so it's like as if for every unit of change you have in your predictors, which is your disease or your illness, you look to see, and you can explain the variability that induces, if you like, in your outcomes. And you can see here that, interestingly, the disease status, certainly as we kind of would expect, did relate to pain and to physical functioning, but not to the distress. And when we do regressions, we're often looking for, you know, if we get about a quarter to a half of the variability being explained, we consider that might be a useful predictor, because you can imagine human behavior is very complex. So we're not going to find a set of predictors that explain all the variability in your measures. But then you can see then the illness beliefs, really, they were kind of explaining between a third and a quarter of women's performance or reports on those 4 dimensions. And so the beliefs that were particularly indicative, if you like, of the outcomes were identity, what the number of symptoms you were reporting, how severe you saw your illness, and that you might have seen it not really amenable to control. And if you have those kinds of negative illness perceptions were related to poor emotional, which is the depression and anxiety, and the illness-related functioning, which is physical function and pain. So they were explaining about a quarter to a third, as I said, of the variability. But disease, not so, which was interesting. And even the illness perceptions explained more variability in physical function and pain than all those medical disease status indicators. So what was the message we took from this result? Well, from this we could see that, interestingly, perceived disease, what you believed about your disease, outweighed the objective disease on those measures of adjustment that we were using. So I think it's important, and would be important for clinicians sometimes, to know that depressive symptomology may derive from non-disease factors. It may be to do with where the person is thinking in their headspace about their illness, and you know, and that's important, not to just assume that depression is just linked with, we say, the flare-ups or whatever, or the level of disease severity that the person has. And so that's a kind of a reassuring approach to rehabilitation, because instead of awaiting improvements in medical status, we can maybe intervene by our understanding people's appraisals and understanding their illness beliefs might help us facilitate their adjustment. So that kind of put Ruth and I on a road of looking at appraisal and cognitive appraisal. And let's look more at these cognitions. And certainly we all know situations where the same stressor, even in our friends, people kind of, react differently, or so we're very interested in maybe why that is. And it is the case that we all differ in how we construe what's happening to us. And there was a very nice theoretical model that came out from Lazarus and Folkman in the 80s. And people have since done research on that now. But really the kernel idea of that was that interpretation of a stressful event is just as important, if not more important, than the occurrence of the event itself. So really that's the tenet of our research that we've kind of continued to do, that how does appraisal of stress, for example, impact on adjustment to an illness? And this is the model from Lazarus and Folkman, and it was adapted later. But if you have a diagnosis like a stressful event, we engage in what's called primary appraisal. We think about that. Goodness, what kind of harm and loss is this going to confer on me? Is this a threat? What are the bad outcomes that are going to come? And sometimes people can, and this is where differences arise, can see a threat as somewhat as a challenge as well as a difficulty. Then when we do that, we engage in a process of secondary appraisal. Well, now this is happening to me. How can I cope with it? Can I cope with it? Have I the ability to cope with it? And if you feel you can't, and there's a discrepancy between your primary appraisal and your secondary, or you're quite overwhelmed by stress. Then after that, we start to engage in and deliver and use our coping strategies. And there's a huge literature on how and why we use coping strategies, but they kind of break down into whether they're problem focused or whether they're emotion focused. And in a problem focused one, was maybe you kind of inclined to go at it, try to alter the stressor, get more information, take steps to ameliorate it. Emotion focused might be, and it's often if a stressor isn't changeable and less controllable, you might have to deal with your emotions to deal with it, and that's how you cope with it. But then in subsequent research, other things began to, said things could come into play that influence these appraisals and the use of your coping. One were external moderators, like tangible resources. Well, it's your economic resources, and that will, of course, maybe make you think you can cope better because you have access to medical treatment, etc. But social support, the people in your network, and the support you perceive you get from them to help you. Maybe what other life stressors people have had in their life recently. That might affect the kind of coping that they'll engage in. And then internal things, like internal psychological things like your personality orientation, how optimistic you are, how resilient you are, or your self-efficacy, your actual beliefs in that the things you do will have successful outcomes. So basically that's the theoretical framework that Ruth and I used to go forward with the kinds of research questions that we were asking. And we did, so if you do perceive stress as a threat, you're going to have emotional outcomes like fear and worry. If you see it as an event, as a stress, that's stressful, but it's a challenge, that is often associated with favorable coping and emotional states. Like you'll feel eager and you'll feel excited, but maybe with the touch of worry. Like, for example, I'm kind of used to doing public presentations and giving research papers at conferences to live audiences. But this one on online wasn't quite so sure how it would all work out. But I still thought of it as a challenge. It was an opportunity to get mastery and have a gain around that. But, a little touch of worry too in relation to it. So we then did a study, Ruth and I, on stress and coping with women, 80 women with arthritis, again, in the hospital. And we did a 12-month follow-up with them. And you can see when we assess stress, we use a scale called the perceived stress scale. And that really tells you, it gives you a sense of how unpredictable or uncontrollable or overloaded or overwhelmed people are feeling in their life in general. And then we used a kind of, we did distress and anxiety and depression, but we also linked into more negative emotional states as well, like how hostile and guilty people feel, or how the positive affect that I talked about earlier, where they fit on the spectrum of being enthusiastic or excited. And we used a coping scale. So, as I said earlier, emotion focused is efforts directed at regulating emotion, and that might be positively reinterpreting the event. maybe having to engage in acceptance around the event. It might be seeking support from other people, for kind of moral support. The problem focus would be efforts that you try to do something, as I say, you engage in active planning. You might look to others or look up the internet for informational assistance, etc. So we used we looked at a range of those strategies. We then clustered them down because there was on our scale there was about 15, so we clustered them down into whether we could describe them as adaptive coping or avoidant coping. Now again, you see the same pattern here in our regression equation. The disease did explain physical pain and physical function, but the stress variables explained all a fair bit of variance on the affect, whether positive or negative, and the anxiety and depression. And so if you had high perceived stress, you'd have low positive affect, and high negative, high anxiety, and high depression. Coping explained, once you put in stress and took account of it, coping still explains some variance. The adaptive coping did explain whether, it was linked with your positive affect. The avoidant coping was linked with your negative affect. So in that model, stress was, again, for women with arthritis, was the strongest predictor. And we also did a longitudinal analysis because we had data at baseline and we had data at 12 months later. And that allowed us to, because some people say, well, is the stress causing the adjustment, or is the adjustment driving and the distress driving the stress? So when you have longitudinal data, you're kind of enabled to answer that somewhat, because you can take your baseline adjustment of depression and anxiety, you can control that in your first step of your regression equation, and then you can look at what how current stress, what additional variance it adds to that. So in this case, we found stress did predict distress over time. So it looks like it's contributing to the distress. And we also found that the different kinds of coping also predicted positive affect over 12 months. So that was contributing to maybe helping to create more positivity in the women. One thing we did find is, and we again did a range of analysis looking to see, was there particular types of coping that kind of intervened, if you like. If you were feeling stressed and you used a certain kind of coping, did that create more distress? And we found, yes, one particular one it's called, if you focus on your emotions and you vent them. Now, you might say, isn't that cathartic to kind of have emotional expression? And certainly it is in many instances, but if you're negatively ruminating on your emotions all the time, to the point maybe of catastrophizing about them, that's not going to be a very adaptive strategy. So we learned that if you are having an intervention, for example, that might be one to tackle and look at with people to ensure that they're not doing that. So the key results from that study, again, we found stress outweighed disease and coping on emotional adjustment. We found that maybe certain kinds of coping could be a mechanism by which stress can impact adjustment. And again, we found, yes, we could maybe facilitate adjustment by modifying stress appraisal, and to a lesser extent coping, because we didn't find, our findings weren't as strong for coping, but they were still there in a limited capacity. So really, in our work then with RA told us that the results fit with the cognitive behavioural paradigm of intervention. So the question then arose, well, if stress is really indicative of depression and anxiety, can it be managed? So we decided and embarked on a randomized controlled trial to test the efficacy of that kind of approach, stress management, appraisal with coping, in reducing stress and distress. And we decided to do so in an illness with high threat, such as breast cancer. And cancer, as we know, bears all the hallmarks of a stressor. It's unexpected, it's uncontrollable, it's ambiguous, and with huge potential for loss and harm. The research would tell us that. So we embarked on this randomized controlled trial, and we recruited 355 women from the hospital, and they were recruited before they were awaiting surgery for their breast cancer. And we had a 61% response rate from the women who agreed, who were eligible to take part. So we were very pleased with that. And you can see the variables that we assessed here in the first phase, and some went in, just half of them went in the later phase. We looked at different stress, general. We also looked at how stressed you were in relation specifically to your cancer. We looked at how you coped generally, how you coped in relation to cancer. We looked at all our emotional outcomes. And also, if you think back to the model, we decided, well, let's look at the role of social support and optimism. And one other thing we included, because there was quite kind of a life-affirming findings in psychology at the time about that when people go through very adverse circumstances, they can achieve what we call post-traumatic growth. So adaptation sometimes can induce these positive psychological responses. Now, it's not a kind of a Pollyanna concept and, you know, be happy and be positive, because sometimes it actually occurs in tandem with distress. You know, the two aren't mutually exclusive, but the kinds of things, you know, people report were, God, goodness, I wouldn't have wished that to befall me, but the fact that it did, I've learned so much, I've improved my relationships, I've enhanced sense of purpose, etc. And interestingly, in cancer particularly, a high percentage of cancer survivors report having benefited in some way from the experience. So with that, we thought, let's look at that in our research. And in the first phase of the research, we had the women at baseline, and after their surgery, about 4 months after their surgery, we did another assessment with them. All these women had localized, most of them were in stage 1, 2. Almost 40% had a mastectomy, others a local excision, and about 41% had both chemo and surgery. And we did this study. We worked very closely with the nurses. When people were diagnosed, they were asked if they consent to take part in the study. And within 2 weeks, they came in for their surgery. And Ruth and I were very connected, as I said, with the admissions office in the hospital. Will Mary or Nora have a bed tonight? And that was stressful. And we went in to meet them the night before their surgery, and we took a week on and a week off. So Ruth and I actually met every single one of those between us, or half each, those 355 women, which I think had helped greatly towards the good response rate and the engagement with the study. And sometimes we had to go back in the day of the surgery if they had come in too late the night before. But anyway, so it was a long study. It took actually 4 to 5 years to complete, but it was probably one of the studies we're very proud of because of the investment of time by ourselves, but also by those wonderful women who took part. So again, when we looked at the same picture emerging here, when we looked at global cancer and life event stress, the stress and the perceived stress in people was really what was driving their depression. And you can see fighting spirit, low fighting spirit and a helplessness was predicting depression. And fighting spirit, but a task-focused approach was predicting positive affect. Now, we kind of found some interesting things on the finding benefit. The variance explained wasn't great, but it kind of alerted us to something. Said, look what's happening here. The people who had more global life events actually are reporting more positive benefits. And the people who, as kind of expected fighting spirit, but then also the people who were anxiously preoccupied about their illness, they were reporting more benefits. So we thought we wanted to kind of look at that later. And also, but we found in this, while optimism and social support might be correlated with the outcomes, they weren't, when in this multivariate package, if you like, they weren't coming out as very strong. So we didn't kind of continue with looking at that. Again, stress was the strongest predictor. It contributed to adjustment rather than just reflected adjustment. And we thought, yes, well, this might be a good tool that women could be screened to identify the people who are poor adaptation. So then we ran our clinical trial. And as I said, because we were following all these women from the different cohorts up a year later, it took quite a long time. And from the time of diagnosis, when we met these women, to their post 12-month follow-up, about 14 months had elapsed. And you can see there that always when you're doing longitudinal research, we started off with quite a high number of women, but through attrition and people were ill and they couldn't take part any further, etc. All understandable. So we looked at stress, distress, and we were really trying to change those, and we call those primary outcomes. But because we found the interesting findings on the post-traumatic growth, we decided, we wanted to definitely include that. So that was we call it a secondary outcome. And the women that came into our 5-week intervention were all in active treatment phase. And that's why I found them so inspirational, and so they were just wonderful to come in and do this 5-week program when they were going through difficult times. But we also hoped that it was going to help them during that time. and the control group had standard care. But also I was very inspired by women who, even when we met them and we said, you know, we might be coming back to you asking and contacting you to do questionnaires, but you mightn't be assigned to the program. Every one of them would say, well, if it helps somebody else, I'm very happy to take part. So they were in groups of 10 to 12 for 5 weeks, 3 hours a week, and they were run by a clinical psychologist. And then we had a post-test. Immediately after the intervention, we measured those things again, and we measured them again 12 months later. But we were very interested in how long does an intervention need to be, and to whom. And we did look around at all the interventions that were done to date, and they all ran from between 9 to 20 weeks. So that's expensive, it's resource intensive, and for time for patients. So we thought, let's devise a 5-week intervention and see how that goes. And you can see the kinds of things we did there in relation to emotional disclosure. We had people write diaries, they had relaxation tapes to take home, they did relaxation, stress appraisals, cognitive restructuring. Because our cognitions, when we appraise an event, our thoughts come first, and those thoughts drive our emotions and our behaviors. So modifying and helping people to learn to think about their cognitions is very useful. So what do we find? Well, we found global stress, it was reduced post-intervention. You can see the block line coming down there for global stress or general stress. Anxiety reduced post-intervention for the women in the intervention versus the control group. And also we found post-traumatic growth did increase post-intervention. But as you can see there, it was interesting, the control women at the 12-month point caught up. So it is a process that many people engage in spontaneously, but we were looking here and said, but still the intervention accelerated it, I suppose. We then did something where I'd said to you, we wanted to see for whom would this intervention might be useful. And we did find, when we did an interaction analysis, that global stress decreased more for people in the intervention group than the control groups, for those who started off, who are quite highly stressed. So that's an important thing to know, that really the intervention might be just needed for people who are high in stress. Now, we didn't find the differences were significant at 12 months, but we did find that the intervention group didn't return to baseline stress levels. Perhaps we might have and should have incorporated a booster session, maybe, or a reminder. And now you can do maybe things online, and you can not just have a one-to-one, you can have Zoom where you can repeat the group effect, if you like. So that might be something worth doing down the line. So the key result then from this was that a shorter program could accelerate adjustment within 6 months of diagnosis, which was kind of post-surgery and inactive treatment, which is important, but particularly so for people who are highly stressed. So that reduces time investment for patients and the financial burden to services. And also that perceived stress could be important for screening and for referral. And in fact, and I often think of the women who took part in this, both women in the intervention and the women in the control, because they allowed us to make the comparison, really did help, because we now have the nurses in the breast symptomatic unit can use the stress scale and they can get a sense of if people are really highly stressed, and they can recommend them for the intervention. And in Cancer Care West, as you know, it's a free service for people with cancer, and there's a lot of psycho-oncology and psychological support there, psycho-oncology services. So our stress management program is available there and is used there for people who need it. So there was a very practical and valuable, I hope, contribution made from that piece of research. And then just, as I said, we decided we'd go further and look at the post-traumatic growth, or the positive personal growth, because amid all this trauma, people can still experience personal growth. And as I said, that's a very affirming finding. So people maybe seem to reframe it as a positive turning point, so they kind of grow, not in spite of the adversity, but because of it. So we were thinking, well, how does this occur? And we looked at the theoretical frameworks in the field. And basically, we all make assumptions about the world, and that there's a kind of a just world, if you like. And suddenly, your world can come crashing down around you. You get this kind of random negative event befalling you that's very distressing. So you begin to think, oh, the world isn't quite as just and as orderly and as morally fair, if you like, as I once thought. So you start to think about that, but you have lots of discrepancies there to begin with. And that can cause a lot of distress, but it can cause you to start thinking about the stressor and ruminating about it and what it means for you. And maybe that's the catalyst for positive growth. The findings when we looked at the literature are still mixed because it's a new area, and there were very few longitudinal studies. So we decided to address that in a study like, does distress and distress contribute to growth? And the only things that the theories were looking at the time were distress. They hadn't even thought about the cognition, the cognitions. And, you know, is post-traumatic growth, is it just a good thing to feel? Is it an existential phenomena? Or does it do anything? Does it have an adaptive influence? So we did another study with women at 5 time points, diagnosis, treatment, and early survivorship, which is 12 and 18 months. And we used a path analysis, and path analysis just allows you with longitudinal data to infer kind of causal connections. So we had what we call one model, and we said, let's try anxiety and depression, but also let's try stress appraisal, the global and specific stress. And let's see what happens with post-traumatic growth over time. Now this looks a bit busy, but you can see here that anxiety and depression, there really wasn't much happening in relation to post-traumatic growth. There was one relationship we found, and if anxiety was related to it at 6 months, but it didn't really reduce distress subsequently at the next time points. But then when we looked at stress, you can see there the red arrow is for cancer stress and the blue arrow is for general stress, and we did find some connections there, causal connections. And the one we were particularly interested in for theory was the cancer stress, and it was related to higher subsequent post-traumatic growth. So if you're thinking and ruminating and you have a lot of intrusive thoughts about cancer, you're probably doing something constructive with those. They're not just causing distress, and they are, but they're also causing something else to happen. And then when we looked at the subsequent 12 and 18 month time point, we found that the post-traumatic growth was associated with less stress over time, and that hadn't been demonstrated previously. So the key result there was, from a theoretical point of view, we showed that stress actually was a more useful determinant, or your cognitions around stress, than was distress. So they did promote positive growth. We were thinking then it had implications for reducing subsequent stress, so maybe it changed people's perception about their future perceptions. So enhancing post-traumatic growth can have subsequent adaptive effects. So we were very pleased, and also to know that our intervention kind of brought that about earlier in the disease trajectory, and that it had such adaptive effects. So we then, when we were dealing a lot with clinicians, we noticed as well, and looking at the literature on cancer, we noticed that the men tend to be a bit more neglected. And so we decided to do a couple of studies on prostate cancer. And I just briefly kind of summarize those for you now. So many of you will know that prostate cancer is a slow progressive disease, but no, and most men are diagnosed with early localized disease. So there's a good prognosis with it if it's caught in time. There's a lot of different therapies for prostate cancer, from surgery to different kinds of radiation. But one of the things from a psychological point of view is that the active treatments, some of them can have side effects like urinary bowel, incontinence, and sexual dysfunction. So it has a potential to exert a very negative effect on psychological well-being. So we wanted to understand that a bit more. But as well as looking at stress, we thought with the men, let's look at if there are some of their personal resources might help them respond at diagnosis. And when we were doing the study on diagnosis, a number of the consultants asked us, would we look at biopsy? As I said, they're also a neglected group, and they had no idea of their psychological needs, for example. So we looked at stress, we looked at mood, we looked at, again, self-efficacy, where your actions you believe can lead to successful outcomes. And we also included another kind of personality variable called sense of coherence. It's really a global orientation to how much a person feels they understand the world, that they can manage situations on their own, and that they can kind of find meaning in a situation. So again, we published a couple of studies on this with the men, we had 89 consecutive men in the hospital at the Rapid Access Clinic. And also we had 114 men attending for transrectal prostate biopsy. And we had measures for the men with diagnosis, their Gleason score, which is really a grading system from biopsy results. And it kind of gives you an idea of the prognosis for the disease. And our men were in the range of 68, and 6 is usually around moderate. And you can see there 38% of them had surgery and others had radiotherapy. So I'm just going to put up the regression for the men with the diagnosis, and you can see again stress is explaining a quarter to a third of the variance, both the global and the cancer specific. And self-efficacy is doing some good work there too, in terms of it's explaining about a quarter of the variance on anxiety and depression. We also looked at confusion, because there's an awful lot of decisions men have to make at the time when they're diagnosed as to, will you have surgery, will you have radiation, will you have brachytherapy, will you have the conventional radiation, and they have to deal with, you know, all that information about risks and outcomes. So it wasn't huge, but stress appraisal did impact on and did predict the amount of confusion men were feeling, and they were related. So for the prostate cancer group, we did find self-efficacy and perceived stress predicted variance across a lot of the mood states there. We incorporated more mood states than we had in our previous research. And we also found very similar findings that stress was the strongest predictor in the biopsy group. And it explained about 1/3 of the variance in the stress for both of them. So the key result from those two studies was stress at biopsy impacts emotional response. And that really alerted us to the fact that, like, why are men stressed? We need to find that out in another study. Like, is it about the procedure, because it can be, you know, a bit traumatic and invasive, or is it about the diagnosis? But whichever way, they need adequate preparation for the upcoming procedure, because as well, and the potential diagnosis, because they're highly stressed during that time. We also feel that sense of personal mastery or self-efficacy could be a protective factor, because the men with high self-efficacy were scoring lower on all those outcomes, those emotional indices. And again, so maybe your screening, you could have men screened for low self-efficacy and high stress, and you'd say, well, those men certainly need some input and some psychological care. And the final study I'll just mention to you, and it's under review at the moment, it's not published, is a study we've also done with 204 men on online survey up to 5 years post-diagnosis, because very few studies had gone beyond 2 years. And we looked at stress again, but we also wanted to look at resilience, and does that help the men in these situations if they're high on resilience? And also we're interested in kind of a new concept in the literature called cancer-related masculine threat. And it's really about cancer impacting on, and particularly the side effects, impacting on your sense of manhood. And we looked at quality of life in this study, as well as all the distress indicators. And masculine threat is really whether your cancer experience and your beliefs is inconsistent with your socialized gender role and masculine self-image. And as I said, you can imagine the kind of side effects and symptoms from prostate cancer can be very demoralizing for men, and they feel kind of diminishes their manhood. And resilience, again, is your ability to maintain your function when you're confronted with stress. It's a very good personal resource to have. So we wanted to looked again at stress and masculine threat and adjustment, but also does resilience help to explain some of the relations or moderate them? Same pattern again, we found the stress the best predictor. The cancer-related identity threat resilience individually were related, but in a multivariate equation didn't come out as strong as stress. But we then went further and we said, well, let's kind of unpack that a bit more and look at the resilience. And we did what's called a moderation analysis. And we did in fact find that that the impact of stress on the stress for the men up to 5 years even post-diagnosis was stronger when resilience was low. And also we found another pathway, if you like, of explanation, that if you took people's beliefs and that they really did feel an identity or a threat to their masculine identity, and that is linked to distress, but it is linked via this pathway of resilience. So it was explaining some of the relationships there. So finally, the key result from that was resilience tends to buffer stress under stress. So again, screening tool, and men could benefit from stress management to allay that distress. And the ones with low resilience were needed most. When we saw it as a mediator between threat and distress, maybe it's that it helps, if you're resilient, it helps you reinterpret that threat, so it doesn't actually cause as much distress to you. And finally, we did find, again, quite a strong impact for stress on quality of life and emotional status, so screening to allow for time intervention. So finally, just the last thing I'm going to say, interpretations matter. That's the main message coming from our program of research. Our perceptions matter. The cognitive appraisals are predictors of adjustment in a range of illness and at biopsy, and we're really seeing that high perceived stress is an important risk factor. The brief stress management program can promote adjustment, and particularly for people who are highly stressed. So it can be more targeted to those. We found for breast cancer that stress appraisals do contribute to positive personal growth. And so maybe that's a protective factor because it reduces subsequent stress. And then finally, in the prostate cancer group, we found that personal resources like self-efficacy and resilience are protective factors against unsuccessful adjustment. And so basically that program of research that I did with Ruth, that our findings really do fit and confirm in many cases and in many instances, confirm the stress coping model. So I just want to acknowledge our co-authors on the papers that I've talked about today, Michael Logan in our school here, Jenny Groarke in Queen's University Belfast, she is related to me, Andrea Gibbons from the University of London, Deirdre Walsh in the Athlone IT, and Jean Skelton, who was with us here as a research intern in the university. And finally, I want to say a huge thank you and an acknowledgement to all our participants, because we really couldn't have done this work without them. And as I say, some of that research really changed my perception in terms of just being very humbled and finding those people who took part in their midst of their trauma and their difficulties, took the time and made the effort to take part in our study. And just finally, can I say thank you to all my colleagues in psychology. NUI Galway School of Psychology is a fabulous place to work, and particularly in health psychology, because there's a huge expert base here now and we're close to the hospital. And it's a really lovely place to work, and it's very research productive. And I just want to say thanks to our head of school, John Bogue, Dr. John Bogue, who really preserves and promotes that positive collegial culture in our school. So it's a pleasure to work there. So I'm going to leave it at that. Okay, so thank you very much.
Thank you, AnnMarie. Really a fascinating lecture. And I see already we have congratulations coming in on the chat. I think it's very, very well deserved. And I mean, it's striking to me in that research, the kind of real critical role that stress plays and how people adjust to diagnosis, and the important work that you've been doing in your research to highlight that. I'd welcome, if there are any questions, we have on the possibility there to take question on either the chat or the Q&A function. Just some comments here. Really love the applied nature of your research, which will have a real world impact on patients' lives.
Thank you, whoever said that.
Yeah, I mean, I'm just looking this, clearly your research, your presentation, your lecture has had a really positive impact already in terms of those that have been attending today. One of the things that I wanted to ask, and as I waited, if there are any other questions, please do raise them on either the chat and Q&A function. Clearly, interventions to help people to manage stress are so important. I mean, what sort of interventions were you encountering in terms of the research that you were doing yourself that you found effective?
Sorry, Sean, I'm just trying to get out of this share screen now, but hold on. I don't know what. Hold on, and I just see, can I? Yeah, there you go. Sorry, what kind of interventions is it?
Yeah, just to talk a bit about those. I mean, given how central stress is in terms of how people adjust to diagnosis, and what did you find people were responding best to? I think one of the things that, and across the literature and as well in ours, is not just the way to get people to think about their cognitions, because people can have a lot of, shoulds and oughts in their vocabulary. I should be able to do this and I ought to be able to do that. Or they can sometimes catastrophize things and get them all out of proportion, or they can minimize things. So there's a lot of strategies that can be introduced in a kind of that cognitive behavioral situation to help people readjust and look at their cognitions, but also look at the world around them or in their illness. What are the cues that are making them stress? What are the things that they're finding threatening? And then and think about, when they think about them, what are their feelings immediately? So it's kind of to try to learn more about the link between their thoughts and their feelings, that they can kind of intervene and maybe not get as stressed or worried or anxious about it, because they can construe it in a different way. And it might be like a lot of people, when they get a diagnosis, they're so worried about what's this going to mean, rightly so, because it's huge. But sometimes instead of thinking, well, I can't control this, I'm going to have this forever,
let's think day to day, but you can control maybe managing your symptoms, and you can have some control around that, because the things you do, whether you take your medication, and you'd be amazed the number of people who don't, whether you have a healthy lifestyle, whether you exercise, can be important. But the other side of what we did as well, and people find it useful, and other studies that have compared relaxation and cognitive behavior approaches said they're both equally effective, is the relaxation side. And maybe people to be able to kind of go into kind of a meditative, relaxed state. And that, you see, as well, reduces the arousal of anxiety, because when we're anxious, it's an emotion, but we're also physiologically aroused. So relaxation and learning, when your stress is triggered and there's a cue in your environment, it's immediately to have practiced that in such a way that you're able to have recourse to that resource, that you're able to calm yourself down. So there's lots of things. And we also used in our interventions diaries. And we actually think that's what precipitated post-traumatic growth. It was that emotional disclosure. And we have published a nice study on all the things and the thoughts that these women felt, and the kinds of stressors they talk about. One thing was illness disclosure to their family. They were always worried about that, and that they'd create harm and fear in their families. So we did that, and we learned an awful lot from that. And they were very moving, I have to say, as well. You know, and the fighting spirit that you saw in those diaries, and really was inspiring as well. But we feel the writing the diary was a good intervention as well. And so it's the same idea with mindfulness and all of those things that are used in intervention.
Yeah. Okay, thank you for that. A lot of very positive feedback. You'll probably see it yourself to your lecture, AnnMarie. A few questions as well. I'll just bring them up here. So what kind of cultural differences have you found in responding to illness in the groups that you've worked with?
Well, I'll have to say, because we're predominantly kind of Caucasian and ethnically very homogeneous in Ireland, and we were doing this study even 10 years ago, Sean, so we didn't, I have to say 95% of the people that took part were, Irish. Now, that's not the case for our online survey. We've had people from the States and all the rest of it, but we haven't actually looked at cultural differences. But there would be cultural differences in even that stoicism, personal agency, the delay in seeking help, whether you believe medical intervention can help. So it is, that's kind of a macro level, if you like, element that you could look at as a predictor of adjustment, but we've kind of more kept to the psychological micro, the individual factors. But it is, and there is studies in America where for European Americans, they would have a higher incidence of breast cancer, for example, but the African American women would have a higher mortality from the breast cancer. And again, that's all for socioeconomic, cultural reasons. So there is loads of research on that, but it's not something we have concentrated on.
Thanks for that. Another question here. Do concepts of emotional intelligence intersect with the models that you have deployed in researching resilience?
They probably do. I haven't come across it as a huge factor, but of course it does, because emotional intelligence allows us to garner a lot of information from the world around us and make sense of it. And some people say resilience might be a personality trait, but others say, well, no, it could be due to a dynamic process of positive adaptation. So if you have more ability to take on social cues from people around you, you learn how to manage situations better, you know how to read situations well, you're not as also kind of cognitively all about information processing, you're also looking at other people's reactions, emotions, and learning from that. And as I said, and because resilience is a learned process as well, from the way we go through crises and the things we learn about ourselves, and then we might learn a strategy that helps us be more resilient the next time. So of course there would be interconnected with what our abilities, if you like, our intellectual abilities are and our emotional abilities in that context.
Okay. I'm just looking at, we're just coming up on 3 o'clock here. I think we might bring things to a close at this point, but just to thank you again, AnnMarie, and as you'll see in the chat, our participants have really appreciated the insight you've brought today to this area. And I mean, repeatedly here, I know that participants have highlighted the really important work that you've been doing and the contribution that it can help provide all of us with in understanding adjustment to cancer diagnosis and dealing with that diagnosis itself. So thank you for your lecture. Thank you for the research you've been doing. And thank you to everybody who've helped us to deliver this lecture, to David Kelly again, to Professor Dan Carey, to Martha in the Moore Institute, and to all of everybody who attended today's lecture. And thank you all for your contributions, your questions, your appreciations on the chat. And
and Sean, can I just say thank you to Cathal O'Donoghue, our Dean, as well.
Yes, of course. And
spearheaded the initiation of the inaugural lecture. So
yes, absolutely. It was our Dean, Professor Cathal O'Donoghue, who had initially come up with this idea, a great idea to run this series. So, and also had given the very first lecture way back in March 2018 to launch the series at that time. So our thanks also to Cathal for that initiative. Okay, thank you all.
Thanks, John. If people can email me if they want to kind of pursue the conversation. So.
Absolutely.
Thanks, John. Okay,
bye.
Thank you. Thank you, everybody, for taking part. I appreciate it. Can't see you, but I'm sure you're there. Bye.
Slán.
Slán.